Yeah, that's fine.
Okay.
Good morning. It's sorry, I had to look at the date. May 19th of 2020. Our guest speaker is here to talk to us about clinical risk vacuum education. Again, anybody on Zoom, if you can mute, that would be great. And Kelly, I'll let you introduce yourself, give us a little history about your background. Okay, meeting controls. Okay, if you need any of that swiped away.
Okay, and I can advance with the space bar.
Space or enter either one.
Okay. Hi, good morning. It's really nice to be here, and I'm really honored and privileged to have been asked to come and see you all. And just a little bit about me. I'm an administrative director of the Office of Patient Relations and Clinical Risk. I'm a nurse by background, and I worked here. Actually, I was a co-team member for 10 years, worked in CCU, cath lab, and telemetry, and did some preventive cardiology and outpatient, which was interesting. So I have a lot of respect for all of you. I still have a nursing license, and I'm always a nurse. So sure, just move me wherever you.
Is not.
Okay, I'll just keep talking.
I can, yeah, I can either change the table or there. That was good.
Does that work out? Okay. Okay, great.
Sorry.
I'm going to keep my mask on, so just know that I have a friendly expression behind us. So I'm doing some educational series of presentations around the PACUs at UMH right now, and this one happens to be focused on documentation. And who wants to hear about documentation, right? You're so busy already, and then everybody's saying, do more, do more. I'm here to really highlight when it's important and what things to include in your notes and what things don't help you, keep you out of trouble, and to know that I'm here as your partner. I'm here to support staff. I deal with patients and families and pre-lawsuits all the time, but my role is to be a broker between the staff and anyone who's alleging that nursing care, or I cover the whole department of anesthesiology, that care is an issue. So my role is to really help figure out what we need to do once the wheels come off, how to support you in ways that are helpful. So just know that my door is open. I have some contact information in here. So if you have any questions at all or just want to chat, just let me know. My office is in the Med Inn. I'm not here all the time, but anyway, so I'm here by pager at any time you need to talk. This is not moving.
Sometimes it's
More advance. What did you do?
I just hit enter.
It's an enter function. Okay. So just a couple of things to talk about today so we can meet our objectives, and some other things in general. I want to leave time at the end for you to ask questions. Also, if you do have a burning question you want to ask right away, I don't mind at all. This is a conversation. So I don't want to, hinder you from that, but I may be getting to it later. So really, what is the purpose of the whole medical record? It has a few functions that I've kind of hit a little bit on, but for today's focus, it's really about telling a story about what happens with the patient in your care. So we're going to focus mostly on the things that you need to document or leave when something unexpected happens.
My bad.
Oops, I think I'm hearing some interference, but maybe someone could mute on the other end. Charge nurse role. So why would a charge nurse be involved in documentation? I'll talk about that. It's really just to support staff, make sure everything's buttoned down, see if you need to call me to check things out, things like that. Patient safety report, what goes in that versus the record? And that's a key thing. Sometimes we see things that probably aren't going to help us later, and I'll show you examples of those. So let's go ahead and enter again. So the reason for a medical record is multi-purpose. Among other things, it functions as a way to get reimbursed for care. So care delivery, if it's not, that's not the number one reason for the medical record, but it is one of them. Somebody's on disability or trying to get disability, they're going to order the medical records and look to see, were they walking properly? What if they fell off the table, OR table? What were they doing before they came in? were they able to walk and now they're not? They look at things like that. Unfortunately, those things don't happen very much in your environment, but they could. So the other is to communicate. So if you are discharging someone from the PACU and they're going up to 4C, for example, it's to communicate what you did here to that other area, so people understand the sequence of meds they got, what to expect. Maybe they haven't urinated yet, and you've given that report already, but this is another way to show that communication. I did let them know on the floor that they were, there was some exception. They were doing a little bit differently. I let them know. That's another reason for this. And then it serves as the foundation for medical practice. I don't know if you are watching any of the trial that's going on TV right now with Amber Heard and Johnny Depp. I'm just being contemporary. They show a lot of exhibits of things, right? Text messages, medical records. Actually, there's only a couple they've shown. I'm just using this just because it's modern. They will show your documentation in a legal case. And so the medical record serves as that focus. And I'll talk more about that. Just a couple of things. I highlighted more about this in the first presentation, but some common PACU OR claims, and a claim means that somebody's saying to care, is it an issue, and that somebody did something inappropriate that led to an injury or patient harm. So you have to show that there was a violation in a standard of care, what a reasonably prudent nurse would do in a similar situation in another facility doing what you do. And that led to patient harm. So you can have patient harm, but it could be just the result of their medical history. For example, maybe they had COPD and something happened, and it's because they were sick. Failure to rescue. So this is where PACU claims around the country, it's not just you or here, showing that we had an opportunity to intervene earlier. And then it becomes, if we'd intervened earlier, would that have made a difference? Or that's where we get experts to look at things. So, and then letting somebody know that the patient's not doing well. That's the first thing I look at, is to see who contacted who, look at the timeline, I call you. And it's not to offer any critique. I'm really just neutral, going down the middle, trying to understand what your day or night was like, too, what was contributing. We can talk offline about things that you think we need to know about as an institution, things like that. So the key thing to remember is the record is the story of what happened with the patients. If you just keep that word in mind, you're trying to tell the story of what happened. Nothing less, nothing more. What happened, right? So you are documenting objectively the facts. It's the key piece of evidence, like I said, in a malpractice case. It could either hurt you or it could help you a lot, depending on how you document it. And I will give you tips on how to do that. It can really be the difference between whether we settle a case or whether we can defend it. So again, doesn't mean writing a novel every time you care for a patient. That's not what we're talking about. We're talking about when things just didn't go the way you expected. So we know time and time again, if it wasn't documented, it didn't happen. And that's the way plaintiffs' attorneys see it. They will just assume you didn't do it. And I've been there. I've been in emergency situations, and I know you're busy taking care of a patient and you don't have time to be writing all this stuff, right? Hopefully this doesn't happen very often, but when it does, there's some things to remember. Just a couple of notes on charting by exception, and they have their advantages and disadvantages. So anytime, like, we have some charting by exception here, you got to move on. There are advantages in showing that over time, trends happened in a particular way or not. It shows abnormalities more easily. You're able to see it. Other people can see it. Oh, heart rate went up. That kind of, I'm just using that as an example. What did we do about it? We gave meds, got better. The disadvantages to it are, if you were, let's say, deposed or something, God forbid, right? It doesn't happen very often. We don't take many cases to court. We usually figure out what we need to do in advance. I'll talk more about that at the end. Remind me if I forget about our philosophy here. So if you were deposed, they'd say, what do you mean by normal, within normal limits? Can you explain that, Nurse Saran? And I need to be able to have a unified response, a pretty clear idea of what that means. How do we define that as an institution? And that's not a big deal. We can get around that, but this is where vague charting can be harmful. I'll talk about that. So everybody needs to kind of understand what your policies are, right? And the policy should align with national guidelines. We use Lippincott a lot for basic stuff like putting in a Foley. Did the nurse do this? If they, removed it without deflating the balloon, then that's obviously not really the way we want to do it. And, we would need to do something else. So policy shouldn't be so tight and so rigid that you're backing yourself into a corner. It just needs to be what would another PACU nurse do in this situation, and we would be able to defend. That's getting a little deep, but let's keep those things in mind. These are the common documentation gaps in every area, and it's with physicians, it's with other people. So telling that story, what happened? If I can't understand what happened, when I look at a record, that's a little bit more probable. You can tell me about it, but I don't see it in the record. So we'll get back to that too if you need to make a late entry in how to do it if you forget something. Mental status changes. So are those what were they doing? A&O times 3, A&O times 3, and their blood pressure 0. There's a discrepancy there. So explaining changes over time, saying they were talking to me, those things are really helpful. When the things are starting to unravel a bit, they were talking to me, they were conversing, his wife was there. This is when you script outside of your standard charting, when things don't go as expected. The depth and quality of respirations. So this is one that's missing frequently from people on PCAs, people who are found unresponsive. We have a lot less of that happening in the hospital than we did before because of PACU nursing has gotten, we keep people here a little longer. We've looked at polypharmacy and how that affects people. So, but depth and quality, if they're really, they're breathing okay, but they're not, they're breathing deeply and things like that, things that you want to put in there if there's some fluctuations. We don't see that sometimes when somebody has a respiratory arrest. Conversations with other personnel. If you talk to a CRNA about something and it's relevant to the story. So remember, it has to fit to the story, not just, do you need to use the bathroom, but, things that will help the story. What was the response? CRNA at so-and-so at bedside, and you want to put their name, okay? And it's not to point fingers, it's for the record. Because if, let's say you and I have to talk 2 years from now and something has come in as a claim, you're not going to remember who it was. And so it'll help tell the story. And so there's a good reason for that. Serious change in condition, interventions, and patient responses. So if there are gaps, somebody's doing great, now they're in the ICU and you didn't expect it, just tell the story, what happened? And you're busy taking care of your patient. We know you've got to deal with that first. Patient safety first. Then we'll talk about ways to help you get that note in to make sure that you give yourself credit for all the things you did to intervene in all the conversations you had. Any questions before I move on? Okay. Keep in mind, the plaintiffs are not interested in the truth. They're really not. So the plaintiff is the one that's asserting the claim against us. Okay, they don't care. They want to take that record and make a story out of it. So fortunately, we don't have, I just want to tell you, we don't have that many PACU cases. All right, there just aren't that many. You guys are really terrific. Your documentation is splendid. Anesthesiology as a department is, really collaborative. So those gaps and holes, they're going to assume things and they're going to exploit that and say, well, nurse didn't do anything after that patient. Look, their, respirations were 4. I don't see that they did anything after that. And then they're in the ICU. So I'm assuming that, et cetera, et cetera, et cetera. Experts won't give you the benefit of the doubt. So if I send this out to a nurse expert outside of Michigan, they're going to go, I don't know what happened. That is unfortunate, right? I can talk to you and that's going to help me talk to a plaintiff, but they could, disprove that. And the burden of proof is on the plaintiff, by the way. They have to prove. If I can't defend it, then they're more in a position to be able to do that. So the jurors, if it gets to that point, like I said, it doesn't happen often here, they're going to just go by these exhibits, and that plaintiff's going to go, look, see, they didn't document anything here, and this patient now is brain damaged. So you guys decide at the end of the day how you want to do this. And that's unfortunate because I know everybody's working hard. So just give yourself some credit and call me if you need help documenting it when something happens that shouldn't have happened. And that doesn't mean it's an error. It just means unexpected outcome. Okay. So the things that should be documented, we'll start with the positives. Okay. Just remember, make sure you're in the right chart. I've had this a couple of times where somebody was covering on a break. And so if you're covering on a break, you are in that chart, you are part of that care, your name will show up. The plaintiff orders the records, you're going to be in there. I've seen people that were busy, and anything you can do to help your workflow, and I think a lot of things have already been done. You may accidentally chart in the wrong patient, on a wrong patient. It's happened before. If it happens, there's ways to fix it. You can call HITS, they'll help you. Okay. Always use complete descriptions. So I'll give us some examples in a minute about that. Chart any precautions you've done for somebody who's unstable on their feet or whatever. More people are falling, they're older, they're sicker. And so, anytime you get somebody who's wobbling around or something like that, make a note to cover yourself in terms of what you did to, you put colite within, whatever extra things you needed to do, your non-skid footwear, make sure that's checked. And then any communication with anybody else that should be documented, include the name, message, and response. And in form of communication. So I think there's that special little thing now that tells you whether it's a page or whether it's a call or whatever. So you don't have to worry about entering all that as much as you used to. So that's good. There shouldn't be a capital C in can. I don't know why I did that, but include the notes on contact patient and family. So this is really important. If you're
Documentation.
there's some concern about, who's going to be there.
No, but when I looked on this,
That the brother said that he will be there until midnight tonight. Patient confirmed, that kind of thing. So something a little unusual, or you're feeling a little, put that in.
and then
And
page ours. So you don't need to worry about that. Don't.
those on the other end, if you could just mute, please, it'd make it a little easier for everybody. Thanks so much. So those contacts, anything the patient said too. So yes, I understand what you told me. And yes, I know that with my left leg, I need to, anything that you need will help the story. Okay. And then documenting something later. If say you were so busy taking care of this patient and then someone else crashed and you forgot to chart. What do? Right? So if you need to add something later, just make a note. It's going to show up timestamped as a late entry, but you want to explain why you're adding it late. Just a brief thing. Addendum from yesterday. And I have a whole slide on specific things to do if you need to do that. Okay. Otherwise, it looks like a cover up. And all you're doing is telling the story, but there's a way to do it that really reflects what happened versus some kind of alleged cover up, which a plaintiff will focus on. Some vague charting language. No change. These are actual things that have been found in records. Okay, not necessarily in this area, but no change in patient's condition. What does that mean? Nothing, right? Usually cooperative with care. So again, that doesn't really tell the story. It doesn't tell me anything unless I'm going to compare it to something. Bladder function unchanged. Unchanged from what? I think that one came from a nursing home. So, but it's that kind of thing that doesn't add value. PO intake adequate. This is important for you guys when they're discharging people. If they, if you've given them fluids and things like that, Document obviously the fluids that you've given, anything they drank, in numbers, not adequate. I don't think you have a box for adequate, but that doesn't really tell volume. Patient seems comfortable according to them or you. Things like that. Vital signs within normal limits. What are the normal limits? And that's where you could be woodpeckered, as they say, about what does that mean? Within normal limits for him, his heart rate was always at 40. Well, you can go down a rabbit hole with that kind of questioning. So things that are really factual versus guesses. Okay, so we're going to talk about what not to put in the medical record. This is just a small list. Symptoms such as complaints of pain without charting and intervention. So if you have a pain score of 8, we don't have anything documented in terms of what how we address that. If that's a change, that's an issue. They'll say, look, you didn't do anything here, or it didn't work, or it did work. So give yourself credit for that too. Patient resting comfortably, the score has gone down. Bed soaked, not helpful, doesn't tell us how much they urinated. They could say, they're dehydrated, and bed soaked doesn't really tell us that. And nursing can say, well, the whole bed was soaked. So they did have a lot of output, but it's imprecise. Excuses and explanations for something should never be in the record. So it's just facts. Pharmacy delivered it late, just put in the facts. Ordered it here, received it here. You don't need to you can put that in a patient safety report, and I'll talk about that in a minute. Just the facts. Those are things that can be exploited. May be true, right? But for your purposes, don't do that. And then what somebody else said, heard, felt, or experienced, unless the information is absolutely critical. So you could say, charge nurse said that brother was going to be at home. Let's say there is an emerging situation, and I heard that from Serena, then that would be relevant to the story, and I could put that in there. But you don't want to put in hearsay about things, because that again is hearsay, and it's not admissible in a case. Don't chart ahead of time. This could get you in trouble. And it's only come up like once, I think, I've been doing this for a while, but in this arena, but it can happen. So just be really careful that you don't document it before you actually do something. Something big, right? We know for medications, let's be real, giving it now. Could be a second before or after, that's okay. But something else, like I transferred them to the ICU, they were transferred to the ICU. You haven't done it yet. That's the kind of thing I'm talking about. Any questions on what not to document? Anything I missed or, okay. So again, we're going to focus on those unexpected outcomes. That's when you want to, spend the time to record the facts of the incidents and the time as close as you can remember. So that's why it's important to, you may have to stay over a little later if it's after your shift. Charge nurses can help you get that done, like maybe not give you another patient or something like that, so you can do it. The timing and the chronology of who was contacted and what was discussed with whom. So one great example I've seen in PACU, I wish I could pull one up right now, but it's obvious that you have contacted the surgeon if you needed to, the anesthesiologist. They're there at the bedside. Then I look to see what they did, right? They want to document what they did. But that really helps. It's like, oh, clearly within minutes they were called, and then they showed up, and then the patient was better. So like I said, make sure those computer logins are correct, and then stick to the facts, avoid opinions. So things like seemed, it appeared to be, we guess, you want to avoid that. Seems comes up more often than not. Speculating on cause. I have some slides on that. You don't want to do that. And then please don't reference policies, because the plaintiff will ask for them, and those are protected. Those are for our quality assurance purposes, and we don't hand out policies to families or attorneys because they can be scrutinized. And so that may seem unfair, like I want, but they can FOIA them and they can get them, and that's great. And then they'll point to your charting and say, well, this doesn't fit with your policy. So I would definitely avoid doing that according to discharge policy or something of that nature. It's best to stay away from that stuff. And I don't see that often, but I do see a couple other things that's coming up. Just a quick note on, if the patient refuses something, what do you do? Or the family, if they're speaking for them or guardian or something like that. So you want to document, there's no concern for imminent harm. Okay. So if there's imminent harm, you got to intervene, right? You've got to save someone from bleeding and you just go for it. But you want to document the refusal, the reason for it. Like, this is my body and I don't want to take that medication and I'll take my chances or whatever. If it's not imminent harm involved, you want to document that you told the physician that, look, they're not going to do this. They're refusing to do something, whatever it is, and document that. And then you want to document the risks of not doing it. So, okay, you're going to take your sling off or something. I'm just making this up. There's a chance that, et cetera, et cetera, et cetera. You know all this stuff better than I do because you're PACU nurses, you're professional people that deal with post-op all the time. So you want to make sure that you explain, that's okay, it's up to you. I'm letting you know as a consenting adult that you could have atrophy or, whatever the risk is. And document that they heard it. I explained it, he said, I get it. Okay, Kelly Saran. Because it comes back, not only lawsuits come into my office, just to let you know, I get what are called grievances. And so a web comment or somebody calls and says, the PACU care was not good. And they let me go home when I didn't have a sling on or whatever. And it's like, I call you and you go, you know what? They said they weren't going to wear it. I'll say, oh, okay, let's look in the record. There it is. I tell the patient, remember, well, I talked to the PACU people and there's a conversation documented that you and your wife were there and you understood that not wearing a sling would cause, that type of thing. Because chances are they haven't read their record yet. It's not in the portal. I don't think you can get the PACU record easily in the portal. So I can just gently tell them that, no, the care is pretty clear, sorry, nobody did anything wrong. Okay, so it's for those kinds of reasons as well. And we follow grievances per CMS guidelines. So CMS, as you know, can show up at any time and they can grab a patient safety report or something the patient's complained about, they want to report it to the state. And so this is where we're partners on things. So those situations where you don't have a good feeling about something, semi-risky, but I talk to them about this. Give yourself credit. CMS comes, we're in good shape. We documented everything. Does that make sense? Okay. So what can a charge nurse do? Those of you who function in a charge nurse role, I'm giving advice. There's no rule or policy on this. Okay, so these are just rules of thumb. I just really want to make that clear. So when I was a charge nurse in the hospital, this is one of the things I did. And then I try to one of the reasons why I got into risk management was because I wanted to help improve ways to deliver care that would really take into account the actual workflow, the actual things that we're doing when we're taking care of patients that are really sick and things that have helped. So this fits right into that. Patient safety and risk management are totally united. We are together, okay, in quality improvement. So they're not separate. So supporting nursing to ensure the documentation is complete. So if I'm in charge and I say to Trisha, I know, that was, how are you doing? You had quite a bit going on over there in that bay. How's your note? We've worked together forever. You've seen my charting, I do okay, but anything I can do for you. If it's a newer person, you may want to say, do you mind if I take a look? You want to be a mentor, a guide, and say, here, let me just offer you a little suggestion. You can fix it on the spot. If you can also remind the person, you know what, if they're at code yesterday, I didn't see anything in the record. So let's talk about it. Let's make sure you document it. Charge nurses don't want to document for someone else. to the extent you can really don't want to do that. Okay. So how can you do it? You don't want to wait days to do this. So if the person's not due back to work, have them do it from home. Call them. It's important when something unexpected happens. Or if you figured it out later, call me and we'll figure out whether it's going to add value to the record or not. Sometimes if it's way out, it looks very CYA, as they call it, and it's better just to leave it out. There are times I've talked to the Office of General Counsel, which is our attorney liaisonship, to say, look, here, I'll give you an example. A patient was discharged to home after a procedure in an outpatient facility, and they were found dead the next morning. And he had quite a bit of comorbidities. I can't remember the procedure that he had, but the physician called me. He's like, oh yeah, what do we do? And the medical examiner was called, and they said, no, this guy died of natural cause. I mean, we're not going to do an autopsy or anything. But he said, there's not a whole lot in the record here about what, where he was going to be at home and who was going to be with them and that kind of stuff in case this comes back. Do we document something now? It had been a week out. And so I talked to the general counsel, and we both agreed it's okay for him. He wanted to add something because he saw the patient before he left, because there was some special circumstance with him, but nothing major. We added a note, but I talked to an attorney about it because we had nothing in there. So it was better to have something. But you don't want to wait. At past 3 days, just give me a call. We'll go, let's figure out what we need to do if it makes a difference. If it's missing a med, you can do that later, but we're talking about these kinds of notes. Mentor them, how best to document, refer to this, PowerPoint, contact me or anyone else at risk. I'll show you how, and we'll help you if it's, something that you're not sure about. Gonna move on. Okay. So some challenges with late entries. This actually happened. This isn't your area. This was another one. So this patient was seen in the pediatric pulmonary clinic a couple of years ago, and there wasn't a documented respiratory assessment or oxygen level. Kind of unfortunate because it's a pulmonary clinic. They went home with the parents in a car seat, and they had respiratory distress on the way home. Parents pulled over and called 911. They were transported to the local emergency department where the patient was emergently intubated. So they call it, you shouldn't have discharged me from this clinic in this condition, et cetera. So you can see how that would play out. All right. 2 days later, the documentation's finished by nursing, and it is respiratory status was unlabored, rate of respirations within normal limits, again, that vagueness, and then stats 97% on room air. So do you see any potential issues with this kind of entry? They're covering themselves, right? Possibly, right? They were normal when I had them in my care. This could be exploited. It shows that we went back to cover us. Once we found out that they went to an emergency department somewhere else, we went back. Can you document something later? Yeah, but you want to put in those things like addendum, talk to me or somebody else, and we'll make it appropriately entered. Late entry, patient, You don't want to put in within normal limits. You want to put those actual numbers. Do you have them? How can you recreate them if you didn't document them? That's an issue. But we have little tricks around that. So that's one challenge with doing a late entry, is things like that, just to illustrate the point. Okay, so this is a bit of text here. So basically, this is a hypothetical story borrowed from another case, from another place. But let's say one of your patients that you cared for after you discharge them here goes to an emergency department after being discharged from you after a same-day surgery. The story is that the patient was found by his significant other unresponsive in his living room on the couch, and she called 911. EMS came, found him in PEA at the scene, and it took 21 minutes to bring them back. The next day, the patient is found to have profound brain anoxia. His partner tells the staff this, okay, and my office is called, let's say. this my partner was discharged from the recovery room when he was not in good enough shape to be discharged. He had too many drugs on board. He has a alcohol problem or whatever they want to throw in there. And they should have known that. I told them at the bedside that, they may or may not have, right? And 5 days later, the patient's taken off life support with the decision of the family. Now, imagine yourself, this is again, unlikely because we don't take things to court that often. And I'll explain when we do and why in a moment. So 4 years, 4 years from now. And can you justify the documentation of your care of that patient? Do you know who you talked to? It's 4 years, you're not going to remember, right? I mean, you're not going to remember. There's so many patients you care for. So why would you have documented anything in this case, this guy looks like he was probably okay before he left, but maybe he wasn't. So that's that time to just make sure you're covering yourself and document that. You could say, look, this is what I do for every patient. Any patient that is setting at 90%, I put on 2 liters, or this is what I do. If you don't remember for the specific patient and you are asked questions, I'll ask you about what was your usual practice? What do you usually do? Well, I usually do this. That can help. So can we defend it? That's the kind of situation that, could come and, haunt you later on. But that's a pretty extreme example. This was based on another case from another place. Any questions on that?
One thing that comes to mind that we do document against our discharge policy, and we say that like our patients have to meet discharge criteria and their pain is at a tolerable level. We removed that number scale a while ago, and now it's just a tolerable level. And as you're speaking to us, saying like not to say vague things, I kind of think like, ooh, that's our policy. So
Okay.
I don't know if I'm sure we would hear about that because it has been in place for 5 years or more.
Right. Yeah, I haven't seen that in particular, the tolerable issue come up.
Yeah.
But I'm glad you brought that up. That is vague. So I'll talk to my attorney colleagues about that and get their recs. Yeah.
Like I foresee that would probably get torn up in court.
Tolerable
I don't
according
know.
to whom, right?
Yeah.
Before.
Yeah, I remember that.
And then I believe, like it was changed, we had trouble like.
I'll
getting
make
the
a note to
patients out.
myself.
And yeah, I don't know, but we say post-op pain and then post-op nausea vomiting has to be a tolerable level for the patient to meet criteria.
Okay.
That's-
If you could point me to that
I
afterward.
will. I'll follow up,
Yeah, look, I personally don't think it's very robust. So we'll figure this out together. Okay. All right, good. So yeah, I didn't realize that it's so nausea and vomiting and pain, right? Tolerable according to whom? That would be, yeah. And maybe it is such that this is the way people have decided in the AORN or perioperative communities that this is, but I don't know. Good question. Okay, great. I like it. Thanks. As a risk manager, I'd say probably not, but there may be a loophole.
That was, it was, the policy was written by our clinical nurse specialist, Denise O'Brien, who was like an affiliate of our Aspen National Association. And so, but there's other discharge criteria throughout the country that they use, like a Eldreddy score, and that's like a true number score. But here at Michigan Medicine, we created our own discharge policy, and it has that verbiage in it.
Okay, yeah, I know Denise. I miss her, and she's an expert, right?
Yeah.
So she must know something I don't.
But talking about this makes me kind of think like,
Yeah, it's not the.
I don't know.
Yeah, it is kind of vague. It doesn't really, let's say I got my, we will definitely explore this, okay? So that we are, we're feeling relaxed, okay? There's always a way to undo something, okay? So just so you know that. So Okay, so let's say I'm angry about, that nurse kicked me out. Okay. I've had a couple people say, like at East Ann Arbor, they're like, they were sweeping around my stretcher. They wanted to get the heck out of there. All those nurses were talking about watching the Johnny Depp trial. They wanted to get out. And, I was in pain. And I kept telling them I was in pain, but they sent me out limping or whatever. And I'll say, well, it says in the record your pain was tolerable. No, it wasn't. Right? So, well, yeah. So nothing to worry about. We
I
can
know,
always
yeah.
fix this up, but I think that we have opportunity. Let's put it that way. Okay. All right. We'll work together on that. Great stuff. That's why I'm here. So we have to tweak things sometimes, right? Okay, good. All right, let me get this scary scenario away from us. Let's move into some other things.
Yeah, and that's what we teach everybody to do.
Yeah.
I think for that, I almost feel like that reason, because I always say, like, you want to make sure that if you're telling your story, you're making sure that it looks like that patient is ready. And I think along with it, a lot of us do put a number in as well, like on the pain scale, but truthfully, to meet our criteria in that discharge policy, that's verbiage right off.
We may need to update that policy.
Yeah.
So yeah, all right, we'll
talk.
we'll talk. Yep. And I work closely with Dr. Dubovoy too, Tim, or so, and anything we can do to pave the way, and for physicians, I mean, for everybody, right? So great. Okay, so some speculation and finger pointing. Yeah, I've seen this in the record more times than I'd like to count. I'll tell you, here's an example. So somebody, they have an arrest in the OR, for example, and now they're shuttled up to the ICU. This was not expected. And then you have a whole new team taking care of them. The intensivists, let's say they're in SICU, new people that were not in the OR, and they are just kind of looking at the record. They heard, well, this patient arrest, we got him back. We're going to admit him. And they start speculating. And they say, patient with hypoxic, respiratory arrest, and they don't know. That's really hard to unring that bell later. I have a case I'm working on right now. It's really difficult to defend because that was not the reason why they arrested. And people are saying hypoxia, hypoxic, and they had some cardiac things. It was not a hypoxic arrest. But the story, like I said, it marches out that way. So people will copy and paste or hearsay. They heard from the PACU physician or whoever transported the patient. Yeah, well, we think it was this, and then they recreate it. My best guess is, so guessing is not a good idea. So just the facts. And then these are actual excerpts from the record from one of my colleagues. They left prior to the clinic because they were short-staffed. So anything about being short-staffed, it doesn't belong on the record because they'll say, UVM is terrible. You guys are short-staffed. And here's an example of what can happen. That may or may not be true, right? But we'd rather not put in the medical record because then a story is made around that. And then the patient was sent home from the clinic for albuterol. They had respiratory distress. They're relating the two. Could have been completely unrelated. We don't know. They're guessing. So best to, or it could look like they're covering themselves. Well, I did find it was the fact that they didn't get that albuterol prescription. That's what did it, So we don't want to avoid that. So errors happen. That's kind of my business. I'll expand on that momentarily for a moment. I'll do it right now. So our philosophy at Michigan Medicine, it's called the Michigan Model. We have it on our web. I'll point you to our website later. There's a whole bunch of things that might be of interest to you, but we're known internationally for our approach to malpractice claims, allegations of things in terms of looking at care that somebody feels was unreasonable. We're going to our 3 principles are that we're going to defend care that's medically or nursing appropriate. We're going to defend it. We're going to say, look, I've got Serena, Tricia, they are experts in this. They did what they needed to do. There's no deviation. We're solid. We're going to defend that, right? Or conversely, if we have a problem where we didn't do what we're supposed to do, And again, you have to have harm related to it. So somebody can say, Kelly Saran yelled at me. She's terrible. That doesn't mean harm. It has to be physical harm. So just to make that point. And then we are committed to learning from our mistakes. So if we made an error, it's not the fault of any of you individually. What lined up, right? So we know about HRO principles, right? We know about the Swiss cheese model, that when a lot of things line up, there's a lot of little things that lead to something at the bedside. And we want to learn from that and share it. So if something happened in one place, it probably could happen somewhere else. We want to share those lessons learned. And if we have time, I'll share a med error I made when I was a new nurse that would kind of highlight a few things. And one being getting in this business of helping to look at systems things so we're not setting people up for failure. So we're going to document this in the record. We want it documented. You told somebody you made an error. All right. I gave you a double dose of something, right? You want to tell them it's their right. We have a policy that you need to disclose errors. You don't know how to do it. Talk to me. I'll help you. So just the facts. This is an example right here. You want to show who was notified about it. Okay. So this stuff happens. How do you document it? Anything that you needed to do as a result of it, nothing happened. Patient stable. I notified the CRNA. Patient disclosed to wife at the bedside. Call us with questions or something of that nature. And then any recommendations. So if you feel a little tired later or something like that, there could be some but we expect the effects of the extra dose of morphine or whatever to wear off. There's no permanent harm. Get a physician to help you do that disclosure so that you can really reassure people there's nothing expected to happen here. Conversely, there could be something that is a result of an error, and you can call me and I'll help you with that. But you really just want to be factual and emphasize what we're doing for the patient. We know about this. We want to be transparent. We're sorry it happened. That's a really quick thing on disclosure. I have a whole presentation on it. It's always okay to show empathy and say, I'm sorry, even if it's not a mistake. So some people worry about, is it okay if I say sorry? You can say, I'm so sorry this has happened to you, that you have to go to the ICU. That's okay. It shows empathy, goes a long way, and people remember it. Every conversation I have with the family who wants to bring something forward, they remember how they were treated more than anything else at the beginning. They're more likely to come after the university if they don't have answers to their questions. They don't know what happened. No one's talking to them, and people weren't very friendly, and they were just, walking on by. Nobody took responsibility. Those are the reasons why they get attorneys. They want answers, and they want someone to pay for it. They want somebody to know how much they affected them. Anyway, I could go on a sermon, but I won't. So all that stuff matters. So this is not really the best example of how to disclose something and put a disclosure in the medical record. This is real. Upon chart review, it was found that propranolol was incorrectly ordered by the resident. Okay, you can see right away there's some red flags here. Upon discharge from the hospital, it wasn't checked by an attending. Patient's husband was notified. I am very disturbed by this event. So you don't want to put things like, your narrative in there. I am really disturbed that pharmacy delivered this medication late and as a result X. So this isn't really the best disclosure note. It doesn't help anything. And it puts somebody under the bus. And we don't do that to colleagues. If somebody needs to be put under the bus in some way, we can talk about it offline, right? If there's a problem with a resident who didn't show up when you expected them to, we have ways of dealing with that, but not in the medical record. Okay. All right. I know we're getting close to.
All right, some patients are coming out.
All right. We're almost there. We have like 3 slides. Okay. So avoid referring to risk management in the record. Don't say Kelly Saran notified risk. You don't want to put that in there. It's a red flag. People will say, oh, some error happened. I've had more patients too. In my chart, it says anesthesia event. And we're trying to get that changed because patients will see event. What happened? That's just the way it's documented. So people will look at things and go, oh, you notified risk management is because you think there's something bad happened, right? They'll jump to conclusions. Also with the safety report or incident report, never put that in a record because that's protected QA information. We want to put all of the things that we wouldn't put in the medical record in there. All right, not hostile stuff, but I waited 4 hours from pharmacy for this critical drug or whatever. That's where you would put the systems things in. But if people know that there was some report, or they may ask me for it, and I'll say, no, we don't give that up because we want people to really be honest about what's happening in their environment so we can make changes if we need to. That is protected, you don't get it. They can FOIA it if they want. So it's just better just to leave that out. More families will go, if they say, I saw that you were notified. I'm like, yeah, well, we want them to notify us about unexpected outcomes. That's our policy, you know, and we're here to just help them. They're like, yeah, well, you know, so leave it out. We all want to know those concerns, just don't put them in the record. Like I said, there's something we need to address as a system. Put it in the report. There's the reporting form, as you know. I'm here to help you, as I mentioned. So Saran, it's spelled, my name is spelled like Saran wrap, but it's pronounced Saran. Okay, like Karen. Hopefully I'm not a Karen, but no offense to any Karens here. So you can always email me, no problem. I like to talk, page me if you want, no problem. And then we have somebody available 24/7 on call for our office. So when the you know what hits the you know what, call somebody, call 1490 when in doubt. And it's under patient relations and clinical risk. It's really not intuitive. If you look on the home page, just 1490. If it's during the day and you don't remember my number or name or anything, they will direct it to me because I know this area and most of you now. So I just wanted to wrap it up and just say that you do incredible work. I'm really proud of the work that you do and the care that you take for your patients and families. And you do a lot of really high intensity things. And, you know, during this pandemic and everything, the stakes have been higher, and I can't thank you enough and for your professionalism and for your partnership with me. So thank you. Any questions? Yeah, great.
Your office's response to the Vanderbilt or roundabout case?
That's a great question. So now she's not going to prison, thank goodness, right? So this is a whole topic. I would suggest you, if you can, and I'll get the date, I have to find out from Nora Naughton, that I'm presenting a risk management overview for M&M in July in partnership with the Office of General Counsel, who is very well versed in the Vanderbilt case, who can explain and do some Q&A. So come to that. It's obviously, you know, in the morning, hopefully before patients, but that'll explain more. In a nutshell, we obviously don't take that approach here, and we will do everything we can to defend. Criminal charges this is really, really unusual, really crazy unusual, and very unfortunate. So to the extent that the mantra here, you know, from everybody in leadership and our general counsel is that we will do everything we can to argue that this is not a criminal offense. Every state has different statutes and different laws, which makes things trickier. So what Denise from the Office of General Counsel will do, that doesn't mean that anything is worse for us, just caveat there. She'll break it down. Like in Michigan, this is how we would, you know, and we probably have a better chance at something like that than Tennessee. They have different statutes there. So we're not into blaming individual people. It's not what we're about. But I've had so many questions from anesthesiologists saying, what are you going to do to defend me exactly? And you know, if I ever got a criminal charge, I would leave the profession. We've heard that. This is a big deal. It's a very big deal, very upsetting. So in a nutshell, again, that's the stance. But when it comes down to what actually is involved in what happened there and what we would do, that will be coming. And she's working on something now for the institution to put out as well. So I have lots of stuff on the case, so a timeline, everything, and some other input. But in general, on the country, leadership, academic centers are, and everywhere else are really against what happened. But legally, that's the question I know everybody's worried about. And I want to provide information with OGC. So that's coming up in July, and I'll give you the date. It's on the calendar of events. It'll be on the calendar of events. I just have to get the date from Nora.
Hospital wide, just in healthcare in general, everybody's got a little different take after that trial. And so I know some people have said here, like, oh, I feel hesitant to fill out a risk report now, almost because of that fear. But that's reassuring what you're saying, that this university supports,
It's taking a stance too,
it's
not
taking
just
a
saying,
stance.
oh, well, we wouldn't do that, like you're actually saying, going against,
Yeah.
Yeah, absolutely. And I probably should have started this presentation with that topic because, why would I call you, Kelly? What do you do for me? People don't know what I do. Then realize that I'm really here to support staff, number one. Okay, I deal with patients and families all the time, but I'm really here to support you and the work that you do. We're here to figure it out together, and I'll tell you about, okay, this will put it into context. Why would you report something? When I was a new nurse, I was walking down the hall, it was a really busy night on the cardiac unit, and somebody had nitroglycerin hanging in a room, and it was not my patient. It was beeping, the alarm was going off on the pump, and I wanted to help out. So I went in and I saw 2 bottles of nitro. One was empty, and then one was full. So I assumed that whoever's taking care of that patient had put that nitro right next. This is a long time ago, by the way. Well, not that long ago, maybe a couple of years. And so I'm like, okay, I'll help out. So I swapped it out. They looked pretty similar, right? Went on my way, didn't change any pump, volume or anything. It was just rate. Then about 15 minutes later, the charge nurse came up to me and said, we need to write up an incident report. I said, for what? I just about had a heart attack myself, and I said, what are you talking about? She said, come into my office. And it was very punitive and scary for me. Just one reason why I do what I do, because I know what it feels like, And she said, that patient in that room, you hung single strength nitroglycerin and he was on double strength. And did you check the bottles? Did you look at the labels? And I was like, they look the same, right? This is before we had a lot of bottles look the same, and you really had to look at the concentration at the very bottom. It was really tiny, right? We've learned a lot over the years. And she didn't tell me anything. She's like, this is going to go in your file. And he has got EKG changes. And, so that was it. And I thought I was going to lose my license. I was crying. I'm like, I'm never going to be a good nurse. This happened. I'm terrible. I'm so, And then I found out, nobody said anything. I felt like everybody was looking at me like, new nurse made a mistake. That may or may not have been true. He wound up being okay. But I just lived with this, not knowing what the heck. I didn't want to bring it up. So about a year later, found out that people around the hospital were making the same mistake with there were 2 strengths of nitro. We don't have them anymore because of this. And that the labels were exactly the same. They had red around the label, and rather than in 2 different colors or something that would have helped. Granted, I didn't look at the concentration, but those are those holes that line up to help us make mistakes. The room was dark. That's another thing. I learned, after that I turn the light on and I look at things, because mistakes do happen in the dark, believe it or not. I mean, darker areas. So I was like, I kind of felt better. I felt bad that this happened, but it's like, I'm not alone. And it was because people reported it that we could make those changes. We had an argument now, like, pharmacy, you better, look, we've had this happen everywhere. So that's a reason to report too, right? Strength in numbers. So I hope that kind of illustrates that need to let us know. You don't want to put anything in the right. You're just worried about something, just call me and we can talk it out. Okay. So anything else? I'm happy to answer any questions. I know you gotta get to work, more work. This is work, right? Okay, thanks so much for having me.
Thank you.
Thanks. If there's another topic that you can think of that would be helpful to you, let me know.
Kevin says thank you.
Great,
All right.
great, thank you. I'm just standing here until we end it.
There we go. Okay,
Bye.
see you guys. Thank you. We're good.
Have a good day.
Thanks. Bye.
Wow, everybody was great, great questions.
I'm assuming that's Christy Courtney, right?
I think so.
Okay, I'm gonna take off.
Okay.
Thank you
Yeah,
so
thank you for
much.
your time. That was excellent.
Yeah, it's nice to see you, meet you. And,
Yeah, and have you in person.
Yeah, no, thanks. It all worked out great. I
Yeah.
was just worried about the technical things. I'm like,
No,
how am I
we're,
gonna do this? But
we are good.
Yeah,
Thank
thank you so much.
you.
Take care.
yeah.
I think we're still on recording, but there we go.